So I guess it's already 1 minute past 4, and it really is a great pleasure for me to welcome all of you. Actually, we were overwhelmed by the reaction from the ESRS community because as of today, we had something like 850 registrations. And I think that clearly shows that insomnia and the new guideline seem to be of high interest to lots of people out there. So my name is Riemann from Freiburg University, and I guess we start with a brief round of introduction from the panel here. And maybe Chiara, you can go ahead and say a few words about yourself.
Yeah, hi, my name is Chiara Baglioni. I'm a professor of clinical psychology at the Department of Human Science of the University Guglielmo Marconi in Rome. I used to work 11 years in Freiburg with Dieter and the Freiburg Sleep Lab, and we still work a lot together.
Wonderful, Chiara. I guess the next one to introduce himself is Colin.
Thanks, Dieter. Welcome, everyone. I just echo what Dieter said. This is a great occasion. I'm Colin Espie, also a clinical psychologist by training. For the past 10, 11 years, I've been the professor of sleep medicine at Oxford, and prior to that, for a very long time, I was at the University of Glasgow, where I was director of the University of Glasgow Sleep Research Centre.
Thank you, Colin. Tiina?
Hello, everybody. So my name is Tiina Paunio from University of Helsinki, professor of psychiatry, and also chief physician at HUS Psychiatry, and I chair a sleep-well research program at University of Helsinki. And it's been a great pleasure to be involved in this guideline process.
Yeah, thank you, Tiina. Maybe I just end with a few words about myself. My name is Riemann. I'm a psychologist, a psychotherapist, and I've been heading the Freiburg Sleep Center at the psychiatric department of the University Hospital for over 30 years now. And insomnia has always been very close to my heart. And I'm really very happy that today we can talk to you and probably also with you if you use the chat function about the new insomnia guideline. So we thought that it might be good to have a few words about insomnia per se before we dive into the guideline. And I guess I have some, oops, my slide is not working. Yeah, here it is. So we've seen that already for speakers, and we've prepared a few slides to talk about insomnia. Tiina, I guess you may start with this if you want.
Yes, so we would like to briefly introduce you with insomnia, its definition and epidemiology and pathophysiology.
Erica, or Tiina, I have a sound problem with you.
I think Tiina froze, so hopefully she comes in and goes out and comes back in.
Yeah. Okay.
Maybe continue. Yeah.
Maybe Chiara, you can continue if you want.
Yeah, of course. Well, by starting to introduce the disorder of chronic insomnia, I think we can starting to say that from 2013, with the publication of DSM-5, the disorder of insomnia is defined as a disorder, an independent disorder which follows its own course independently on whether it presents alone or in comorbidity with other mental or somatic disorders. So this, in this light, the diagnostic criteria defined from the DSM-5 are presented, and to have a diagnosis of chronic insomnia, the patient have to complain either difficulty initiating sleep or maintaining sleep, or early morning on awakening, or also all the three together. And this should be associated with significant daytime impairment in social, occupational, educational, academic, behavior, or other important areas of functioning. Now, we will see maybe in the next slides that in the international classification of sleep disorders and in the ECD, also daytime symptoms are listed compared to the DSM. And there is frequency criteria. The disorder has to be complained for 3 nights or more per week, and at least from 3 months. And the disorder has to occur despite adequate opportunity for sleep. Like, for example, a parent after 2 weeks of that his or her newborn is born, that might be not the situation for a chronic insomnia disorder. And the disorder is not better explained by or not occur exclusively during the course of another sleep-wake disorder. And it is not attributable to physiological effect of a substance, and coexisting comorbid mental or medical condition do not adequately explain the predominant complaint of insomnia.
Yeah. Sorry. Yeah.
Should I go further?
Yes.
The disorder is highly prevalent. These are data published in the previous guidelines, published in 2017, which showed that in Europe, around 10% of the general population present chronic insomnia clinically significant. The prevalence of symptoms of insomnia is much higher, gets to about 25%. And we need to consider that in some population, the prevalence is even higher, as in patients with other mental or somatic disorders, or even parents of young children, or college students, or elderly. So it is a very diffuse and common disorder to suffer.
Yeah. So maybe, Colin, you want to switch in and say a few words about some classical models?
Of course. I mean, just to echo some of the things that have been said there, there's reference in DSM-5 documentation to a paradigm shift, and I think it was a really important point in time. This kind of recognition that insomnia is a disorder in its own right, and that therefore it should be actively treated rather than seen as a secondary characteristic, perhaps, of mental health or physical illness, or even other sleep disorders. So, but the evidence base had been there for quite some time. But it's finally recognised in these more contemporary diagnostic criteria, and still we see that insomnia as a diagnostic consideration is a very common problem, which leads on to think about, well, how do people develop insomnia? And this is a kind of multifactorial model which was brought into the insomnia field by Art Spielman. It's a generic model that's been used to understand the way illnesses may occur in people who are in some way predisposed to them under certain risk factor precipitating circumstances, and they may also be perpetuated, through that premorbid acute, early, and chronic phase. And I think it's important to recognize the work that people like Art Spielman did over the years in helping us to understand how we may not just diagnose insomnia, but formulate it. In other words, have an explanation for a patient, but why it is that I've got this problem just now. And that's what a formulation-driven approach helps us to do. So say, well, these are characteristics which may to some degree have predisposed you to be vulnerable to develop insomnia. And then perhaps at this point in your life where you were under stress, there was precipitating factors that led your insomnia to become a problem for you. But then perhaps most importantly now, factors since then and now have led to the insomnia keeping going. And this is one of the really important things that we've seen in the literature, that insomnia is not something that just naturally remits, even as much as depression does. It tends to become more of a chronic long-term condition, which then leads to risk for the presentation and the maintenance of other problems like depression. So Art Spielman's model still continues to be very relevant today, I think, Dieter.
Yeah. So I always have problems in shifting this forward. You want to comment on the famous Charles Morin model?
Yeah, well, this is from Charles's book way back in 1993, and I'd provided a very similar model around the same time, a couple of years earlier. But really, it's to do with the fact that there's an interaction and between events. Insomnia is often the culmination of a multifactorial system where difficulties in regulating arousal and difficulties in down-regulating arousal at bedtime or during the night when one wakens up, either physiologically or cognitively, but indeed also emotionally, people become concerned about being able to sleep. So a vicious cycle emerges in which the sort of foundational challenges in de-arousal are exacerbated by what we do about that, our habits to try and solve the problem. And these include things like developing sleep incompatible behaviors and spending excessive time in bed, having irregular schedules and napping during the day in order to try and catch up with lost sleep. And that's connected in Charles's model, and in all models of insomnia, with the kind of dysfunctional cognition aspect, worrying about the process, attempts to control the process, and having unrealistic expectations, which in turn, of course, that strengthen cognitive arousal and emotional arousal. But really crucially, and I think this is important, the consequences here, the things that drive people to seek help with any medical condition are often the consequences of that condition upon their ability to function. And the way I usually explain this to people is that when you break your leg, the reason you go to the emergency room is because you can't walk. That's the thing that convinces you there's something seriously wrong and I need to do something about it. It's the consequences of the event or the process. And so it is also with insomnia. There is very often the fact I'm no longer coping during the day. My performance at work is being affected, my ability to regulate my mood, my emotions, I'm feeling tired. I'm not the person I normally would like to be socially. So that individual then, with both the difficulty sleeping at night and the consequentials of that being challenges in functioning during the day, lead the person very often to say, I need help with this insomnia. Insomnia is really a kind of 24-hour problem in that sense. It's not just confined to the night.
The way I say a few words about the last slide, because we in Freiburg have been very interested beyond the psychology, also into the neurobiology of insomnia and doing lots of work into hyperarousal. And this is just a summary. What we think what goes wrong with the physiology in insomnia. We can measure changes in the EEG during sleep, more fast frequencies, more REM sleep arousals. We can measure alterations in the autonomic system, increased heart rate, and we can especially measure alterations in the HPA axis, meaning people with insomnia have an increased output of cortisol, of the stress hormone. That means that the disorder is not just like, say, a fancy psychological complaint or something, but it is really ingrained into the biology, and there are also genetic factors involved there. And I guess that really summarizes what we know, and we have many more models going on, and we hope that in the future, one day, we will be able to fully decipher us on a psychobiological level what is insomnia. So let's switch, and I think most of you came for the guideline, and I guess we kick off with a kind of summary of guidelines. And maybe Chiara, you want to say a few words about the background. What changed in 2016 with the ACP, with the American College of Physicians?
Yeah, before 2016, I think the interpretation of insomnia treatment was much more shifted for pharmacotherapy. Especially there was a big distinction between like more medical oriented training professionals who supported more the pharmacotherapy for insomnia disorder, and the people who came from a career of clinical psychology, of psychotherapy, supporting more the CBT for insomnia disorder. Then since 2016, several guidelines have been published. We are speaking today about the European guidelines, which have the first publication in 2017 and the update now in December 2023. But in this period of time, many other guidelines have been published from US, from Britain, from Australian and Asian countries, all given a new perspective and overpassing this distinction between the medical world and the clinical psychology world, and getting to an evidence-based approach, which is what the guidelines follows, as we will speak afterwards about the procedure of the guidelines. The guidelines for a diagnosis and treatment of disorder are supported by a process of reviewing of evidences. And for this reason, I think interpretation might be overpassed, and different professions and training areas might agree. And I think the main point, which is also supported from the updated guidelines, is that all guidelines recognize the cognitive behavioral treatment for insomnia disorder as the first-line intervention for the disorder.
So maybe, Tiina, you can comment on why did we need a new guideline? I mean, 2017 is not such a long time ago. Why another guideline 6 years later on?
Well, insomnia is becoming more and more widely recognized, of course, by the society, healthcare society, providing medical care, and the insomnia treatment, the basic treatment CBTI, is more and more widely used in different formats, so that we also need to kind of update what's the situation. Is CBTI used by digitally or face-to-face, and guided and non-guided formats? And then on the other hand, we also gain perhaps more experience when it doesn't help. So are there any alternatives there? So there is new research data and also new experience by healthcare professionals, which in a way give us an impression that we need to update the guidelines, even though perhaps not so large changes are there.
Yeah. Colin, maybe you also want to comment on that, because you were so instrumental in many parts of it.
Yeah, I mean, I think it's a sign of as Tiina's saying, increased recognition of insomnia as a disorder that we should be actively treating, not expecting that if we treat an associated condition that the insomnia will inevitably improve. So I think there's greater interest in actively treating insomnia. There's more research to report, and I think, you know, very often when one does a mixed review, one can find, well, there's really not so much being written in the intervening period that maybe it's not justifiable. But in that intervening period, since the 2017 guidelines, and I guess the literature was then up to around 2016, 15, 16, over the last number of years, there have been a lot more studies published, more meta-analyses published, and also in a broader range of outcomes. You know, rather than just can you treat insomnia and change a insomnia experience and insomnia related outcomes, but there's been a broader range of outcomes explored in terms of, you know, parallel associated conditions. Does improving insomnia affect anything else? Quality of life, medical outcomes, psychiatric outcomes. I think there's been novel compounds have come into the market and into the clinical interface. The dual orexin receptor antagonists, for example. So novel compounds in the pharmaceutical field, but also in the CBT field, novel transporter systems for the CBT intervention. For example, using digital means as a way of delivering CBT, and there's been a lot of research in those areas. So I think there's many good reasons to update the ESRS guideline.
Yeah, so it came out, I think 10 days ago it was published, and we have a nice set of authors here. I think we have 45 authors from all over Europe, and not just Europe. And you may ask yourself, how was the process to put this together? And I guess there was a small core group involving all the 4 panelists here. And then the group grew and grew and grew, and many more people said, I'm interested, I'm working with it. And I guess it really reflects, here we have the range of European specialists, therapists, clinicians, physicians, psychiatrists, neurologists, pneumologists, epidemiologists. So we really tried to have each European country, if possible, if there was a specialist, and we have to try to have as many subspecialties as well. And I guess in the end, we had a very lively discussion. Maybe somebody of you wants to comment. This was not just one meeting or writing, but actually we tried to keep with the evidence. And maybe Tiina, you wanna say a few words about that?
Yes, there was a really process within this process, so that we followed good practice by discussing and reviewing several times. So Colin, perhaps could you describe process from your point of view? What was your part there?
Well, I think the slide really describes the process here. I mean, one wants to see this as an involved process with expert review and consideration, but informed by evidence of the highest possible standards. And people will be familiar with the grading of evidence approach, where a systematic review or meta-analysis is the highest level of evidence representing high-quality randomized controlled trials, where one is able to draw some metrics from the combination of results, so idiosyncrasies are somehow removed or managed by that process. Level 2 evidence, of course, being one high-quality randomized controlled trial, at least one. And then as we go down the evidence pipeline, of course, we've been very fortunate, I think, in our field that for a very long time, there has been a lot of high-quality evidence in how to manage insomnia. Not new, but we've had more of it. And we use that grading approach again as part of the review leading to the guideline. As Dieter was saying, there are a lot of people involved in this process, but there's also important, healthy, and robust debate amongst people who are part of the group. It's not just attending a meeting, it's actually participating actively in the review process. I don't know if people want to say a little bit more about that, but I think that is an important element of it.
Yeah, maybe
yes.
I can add.
Yes, Dieter, go ahead, Dieter.
I can add a few thoughts. Actually, there was a co-group preparing a first draft, and then this draft was circulated. I don't know how many times. I never counted the emails I had. And then we had 2 online meetings where we discussed what was written in the drafts, and there was really an extremely lively discussion. So there's one point, the guideline is evidence informed, but it's not that the evidence automatically, like an algorithm on Google or something, translates into statements. There's always a discussion, there's always a weighing of the evidence. A meta-analysis is not like, meta-analyses are different, have different qualities. And there may be very good meta-analysis, there may be poor meta-analysis according to methodological standards. And all that information has to go into that process of weighing the evidence against each other. And we had very adversarial discussions. It's not like we all said, wow, that's beautiful and everything agrees and we're all good friends. And no, it was not the case. There were many critical points, and in the end, what you do in a meta-analysis, you reach consensus, and it's a voting procedure, but it's not we were not happy with a simple majority vote like 51% to 49%. That would not have been acceptable, but usually all decisions were on the level in the end after discussion of at least 80% positive votes on what we, in the end effect, what we wrote in the guidelines. So it's a democratic process, but we really go for want a huge majority behind each statement there. And I think we were able to reach that level of kind of democratic consensus and vote in the end.
Yes, there was an open air in the discussion, so one could really contribute to the discussion. I wonder if we should now go then forward and discuss about what's new in the diagnostics. So Chiara, would you like to tell about that?
Yeah, of course. I think from 2017, the most important update in the diagnostic is the new publication of the International Classification of Disease from the World Health Organization, which actually aligned the definition, the diagnosis criteria of insomnia with the DSM-5 and the International Classification of Sleep Disorders. So as Colin was saying, this is really one of the most important change in our knowledge of insomnia, in our clinical and research knowledge of insomnia. This change of paradigm that we now define insomnia as an independent disorder which has to be actively treated, whether it is presented alone or in comorbidity with another disorder. And so about the management, as consistently with the previous guidelines, to make a diagnosis of insomnia, you actually base mainly on clinical interview, which has to include a general physical and psychological anamnesis and a sleep history of the patient. Crucial instruments are a clinical interview, sleep diaries or 7 or 14 days. We have the availability to have also published the consensus sleep diary, which gives a format to follow for everyone, and questionnaires. And it is important, I think the guidelines as directed to clinicians who might not necessarily be expert of insomnia or sleep. It gives also information about sleep and insomnia questionnaires. So for example, there is one questionnaire, is the Pittsburgh Sleep Disorders questionnaire, which is often used also for the evaluation of insomnia. Despite the importance of the Pittsburgh Sleep Disorder questionnaires, this is not an instrument which is specifically taught for insomnia disorder. It's more a measure of the presence of different sleep difficulties or different nature. So other questionnaires should be actually used if we want to have a more appropriate evaluation of insomnia disorder, as the Insomnia Severity Index or the CSCI, the Sleep Conditioning Index. And so these are the main instruments. Actigraphy is very used, always like the technology going farther gives possibility to have more easily available instrument to use to get actigraphical data. However, this is not necessary for insomnia disorder unless you suspect possible case of irregular sleep-wake schedules. In some cases, it might help to follow the adherence of the patient to the prescription during the treatment, but it's not recommended as a necessary instrument in the diagnosis of insomnia disorder. And polysomnography too is considered the gold standard for sleep measure. Is not an instrument which is necessary for a diagnosis of insomnia disorder. It should be used, however, when there is a case of suspicion of comorbid sleep disorder. Or it is also recommended if we have patients who show treatment-resistant insomnia after the CBT intervention. And I guess you want to add something about it?
Yeah, I guess we had an important discussion about so-called COMISA, which means sleep apnea comorbid with insomnia. Actually, when I grew up in the sleep field 30 years ago, 40 years ago, we always thought that, well, sleep apnea is one thing and insomnia is one thing. Sleep apnea, you can measure things, something is wrong with respiration. Insomnia, this is psychophysiological, this is tension, this is arousal, whatsoever. And very rarely it happens in the same patient. But now there's a lot of evidence out there saying that maybe up to 30% of patients with insomnia also have, patients with sleep apnea also have insomnia, and vice versa. And we clinically, we see it more and more often. And I guess these are the cases when you really need to check out for that. You need to ask, even also in insomnia patients, the bed partner, does the patient snore? Are there breathing pauses, stuff like that? But still, in the end, if you consider insomnia, it's still a diagnosis based on the subjective experience of the person who has insomnia. And there's a lot of work going on looking for more objective markers, technical markers, but we are not there yet. Colin, you want to comment on that?
Yeah, maybe just a couple of things on the appraisal of insomnia. I think just to reinforce what Dieter was saying there, I think it is very, very important that we recognize comorbidity of insomnia, not just with mental health conditions, not just with concurrent medical conditions, but also with concurrent other sleep disorders. And Komisa is a very good example of that. Another comment just to make, you asked earlier on, Dieter, what's new about the diagnostic management of insomnia and so on. I think one thing that's new and is emerging is the context. Very often with guidelines on insomnia over the years, or indeed over the generation that we've been involved in this, we have been kind of speaking to ourselves as insomnia or sleep specialists who are interested in this area. But most other people think, well, that's not what I do. That's a kind of specialist kind of area. I think more and more people will be referring to this guideline who are generalists in their medical practice or their clinical practice, and that recognize the need now to know more about how do you diagnose or assess insomnia, because I should be doing this as part of my routine care. So although the diagnostic considerations here are not necessarily hugely different from ones that preceded, I think the context is ever evolving, in terms of people being interested to know, how do I assess insomnia? Therefore, when we mention measures that are useful as assays of that, like the ISI or the SCI or the clinical interview questions and so on, there's going to be many people saying, where do I find that? Where do I copy of that? What is a consensus sleep diary? I'd love to be able to have that in my desk drawer, to be able to use it, or on my computer screen to send to a patient. And I think that's really, really important and very welcome. I think one of the challenges around objective appraisal of insomnia has been, for a long time, the mismatch, if you like, between self-report and our ability to measure sleep using objective means. I think often that has been seen as a way of questioning really the validity of insomnia. But rather, I think the challenge now very much is that the person's experience and the durability of this complaint within the individual and across generations of complainants demonstrates to us that there is something that we have yet to find that is an objective equivalent of the subjective experience. Much in the same way as some people were still trying to find, well, how do you measure psychosis? How do you measure depression objectively? Very, very important mental health conditions or chronic pain, physical health conditions that are very dependent upon self-report. And I think one of the challenges in finding objective markers is to take the valid gold standard of the report and find something that matches it, rather than the other way around. And I think by looking at only the other way around historically, we have been unsuccessful in finding good markers of it. So that's a research agenda going forward, I think, Dieter, an important one.
Yeah, I think, that's exactly the point. We're still with this subjective experience of our patients, as we always are in the mental health arena, but we are optimistic that we may add objective markers, biomarkers to that. So let me go ahead and switch now to the therapeutic arena. So here is just an overview. I think we don't have to go into so much detail into that. What is CBTI? CBTI is not one treatment, but Colin, what I've learned from you over the last years, it's a set of different treatments which we use as a combination treatment. We have relaxation therapies, we have cognitive techniques. And one point I'd like to make here, we have sleep hygiene, and there's a huge misunderstanding about sleep hygiene. I think many people outside the insomnia field think that sleep hygiene is cognitive behavioral therapy. That's a huge misunderstanding, and many people think if they use sleep hygiene, they're doing cognitive behavioral therapy. That is a misunderstanding. Sleep hygiene is a set of rules. It's a lot of it is quite common sense. Don't drink coffee in the evening and stuff like that. And it's a tiny part of the CBTI approach, and not more. If you do sleep hygiene, you're not doing CBTI. CBTI is much more, and it has the behavioral techniques like stimulus control and sleep restriction. And we come to sleep restriction later on, why this is so important. And we have lots of techniques how to influence sleep disturbing cognition. So that is what we do with CBTI, and usually we do it in 4 to 6 sessions. We do it in single therapy, we do it in group therapy, we now do it digitally. You can do it with a self-help book as well, but we come to that later on to the point. And now I thought we just really jump into what do we recommend. We have, I think, 10-15 minutes left. We want to have some discussion at the end, or some question and answers. And maybe Chiara, you want to start with treatment considerations in general. What do we have here in the new guideline?
Yeah, I just start with a very short comment on what you said. I totally agree about your comment on sleep hygiene. And I think it was already quoted in these guidelines. And maybe we can, in the next guidelines, it will be even more deepened. I think the concept of the 5 principles of sleep health that Colin proposes and publish, plus the sleep health dimensions, help much more with the psychoeducation part as the sleep hygiene part, and might even substitute the sleep hygiene component of the CBTI treatment, which is might be important in some specific population, maybe an adolescent, so, but in most patients with insomnia, actually, you do not find altered sleep hygiene. And then coming to the slide of recommendation for the treatment of chronic insomnia in adult of all age, the main consideration is that insomnia disorder should be actively treated whenever it is presented, as we were saying. So whatever it is presents alone or in comorbidity with other somatic, mental, or sleep disorder. In the presence of comorbidities, a clinical judgment should decide whether insomnia or the comorbid condition are treated first, or whether both are treated at the same time. And anyway, it should be a decision together with the patient. The clinician should give his or her expertise and proposing the options of treatment to the patient with the important information, and then the decision should be taken together. And CBTI should be provided as first-line treatment for insomnia disorder in adults. So the guidelines were specifically focusing on the adult population, and of any age, of any gender, and regardless of comorbidities. And I think an important point that we might discuss is that we add that CBTI might be delivered either face-to-face or digitally, and a stronger attention to the specific components, as Dieter and Colin were saying. We don't speak, Colin taught us to don't speak of CBTI as a one thing, but as a group of different interventions. And many studies have been published, and much research is going on about mechanism of single strategies, which is important to understand how each intervention works, and to deliver an optimal and more personalized intervention to the patients. you
Yeah.
want to add to that? Yeah.
Yeah, maybe I go ahead. I mean, the real newcomer here is the digital aspect. And I've even at the eSleep Europe, I was invited to give a talk about that, and I called it, is it a game changer? Do we have a game changer here? And just allow me a few words about that. This is a table from the guideline, and we also analyzed how many meta-analyses are out there looking at self-help insomnia and digital insomnia. We found really quite an impressive amount of studies showing that the digital approach is comparable to the face-to-face approach. And actually, to be very honest, but we can collect opinions here in the panel, 10, 15 years ago, I was a bit skeptical about all the digital hype, and I thought, well, finally they want to take away psychotherapy from us, and algorithms are doing our job, and what a cruel technical word that will be. But I have to be very honest with you, I've really changed my opinion in face of the evidence. But maybe we can collect some ideas. Tiina, what was your opinion first when you got to know there's a lot of digital therapies out there now?
Yes, exactly as you. I was very critical in the beginning. I mean, like 20 years ago when they emerged into the field of psychotherapy. But then little by little, evidence for many medical disorders and their treatment has been gained that digital therapies are good also for anxiety disorders, at least of not a very severe form of anxiety disorder, and similarly to insomnia. So the data starts being there. It's an effective way of treating. And if you think from the point of view of the patient, so not all are close to healthcare system to visit their groups or therapists, so that then having the remote access can be very convenient if you live in a rural setting. And then some patients actually prefer being at their homes when they do the therapy. They prefer being at their safe home environment. So I think it's a really a wonderful alternative. Mm-hmm. What about you? What do you think, Colin? You have been studying these therapies effectively.
Yeah, so thank you. I mean, let me declare a conflict of interest here, though, because I've been involved in the development of one digital therapeutic called Sleep Heal. So I want to stay very much at the category level here. I think we have a duty of care. If CBT is a treatment of choice, and let's bear in mind that it's not just the ESRS guidelines that are concluding that this is the case. The American guidelines, the American Academy of Sleep Medicine guidelines, the British Association for Psychopharmacology guidelines, all kind of seem to be coalescing around CBT as a treatment of choice for first-line insomnia. I think we have a duty of care to think, well, how do we actually get it to people? After all, if we take a different example, and Tiina mentioned anxiety there. If you say what's the most common treatment for anxiety in practice, or what's the most common treatment for depression in practice, probably would be an SSRI, most likely for depression for sure. But if you could only get your SSRI by injectable from your doctor, it would not be a very promising treatment for the community, because it wouldn't be accessible in a way that is scalable. And I think that's potentially what digital is doing. It's simply, and that's why I mentioned earlier on, I think it offers a transporter system for CBT that can be readily provided to people. If you think the equivalent of going for your injection of an SSRI or going for your treatment of insomnia to a clinic, you don't treat patients that way. So I think, what rigorously conducted trials have been completed, and they're being robustly supported meta-analysis, then we can begin to conclude that digital is an important offering that extends care. I was skeptical at the beginning. I insisted we did placebo-controlled trials in the beginning, because I wasn't a believer. I was really there to say, how do we know this approach is not just a placebo effect? So I think we need the same disciplines around any new treatment or any new transporter system, whether that's a drug or whether it's a CBT intervention or a component of CBT. we just need to do the hard yards, and the literature seems to be supporting CBT still, even when in this other delivery format.
Yeah, thank you, Colin. I guess we wrap up the CBTI part now. There is one more slide left relating to the digital. Oops. So, and actually, but you can find that in the guideline. We digital applications only should be used when they have undergone quality control, quality assurance, like any other medical product. And we now have, I think we have digital products applications in 5 European languages, in Dutch, in English, in French, in German, and in Swedish. And in many of these countries, these applications are reimbursed by healthcare insurances. So that's really a very important step forward. Maybe just one brief comment. If we talk about, like, we have 10% insomnia in Europe. We always think that all of these people seek help. They do not. There are data from Germany indicating there's like 8-9% chronic insomnia patients in the adult population, and only 10% in a given year seek professional help. So 90% go untreated. And I guess that is where especially the digital applications can really help to reach these people. So, but we have one more important therapeutic point there to be discussed, and that's medications. And maybe, Tiina, I may ask you as a psychiatrist to briefly comment on what we have here and what the guidelines say.
Yes, and I hope the connection is okay.
Yes.
So medication, certain medication has the greater recommendation A in these new guidelines if CBTI is not effective or effective enough for an individual. And there are benzodiazepines and benzodiazepine receptor agonists, which are the grade A, as well as then orexin receptor agonist and daridorexant there. However, their long-term use is not recommended. So it's generally up to 4 weeks, and in some cases it can be longer with some medication, such as daridorexant for the time being. But we certainly are awaiting for more evidence in the long-term usage of medication, as well as in intermittent usage. Then the sedating antidepressants low doses are used quite commonly in patients, in particular if there's a comorbid depression there, and to this end, so there is for low dose sedating antidepressants such as trazodone or so that's, I think, in summary about the medication. And then of course there is this slow release melatonin, which can also be used long term in some cases in individuals over 55 years of age. So
yeah, I think there is at present in Germany there's a huge melatonin hype. It's really huge. It's for kids. It's for young. It's for adolescents everywhere, for neuropsychiatric problems. If you go to a pharmacy, you can buy melatonin jelly bears. What do you think about that? Is that justified, that hype?
Well, it looks like the evidence is not very, very strong for insomnia. It's mainly if there is circadian factors, then it might be more effective. But if no circadian factors, so then we came to the recommendation that melatonin as such is not effective in treatment of insomnia.
Yeah, maybe we have a brief round of final words from everybody. We have 11, 12 minutes left. We have 10 questions in the Q&A. So, Colin, just a final comment online.
Yeah, I mean, just to comment on the pharmacological interventions, I think it's great that we've seen over the recent years a real refreshed interest in insomnia management and new compounds, new treatments, and new very exciting potential therapeutic mechanism of action with the DORA drugs coming in. I think that's great. I mean, the key thing that I would advocate for, and the guidelines there to support, is that insomnia should be actively treated wherever it presents. This is really, really important. It should not be and should never become a disagreement between different approaches to management. If you think about chemotherapy and radiotherapy, the key thing is we're treating cancer, right? And that we use all the treatment tools available to treat disorders fully and well. So therefore, the future is likely to be more strongly based research on both pharmaceutical and cognitive behavioural interventions. And I think that can only benefit patient care. And of course, the two things are not necessarily mutually exclusive. So I think it's an exciting time. It's an exciting time with more and more people having a stakeholder interest in the management of insomnia, rather than just sleep medicine specialists or behavioural medicine specialists or whatever. Something that GPs will be more and more interested in, primary care specialists and people from all backgrounds. And of course, the guidelines refer particularly to adults, but there is more and more need also to be thinking, and it's probably something ESRS will turn attention to, guidelines for younger people too.
Yeah, Chiara, you want to have a final comment?
Just a quick addition to what Colin said, which I agree completely. By opening to not sleep medicine experts, I think especially there is a call for many more CBT, clinical psychology experts enjoying this process, which is part what also the European Academy for Cognitive Behavior Therapy for Insomnia is doing by promoting high quality training around European countries, which are the experts in CBT and in insomnia and in sleep psychophysiology are the most qualified person to deliver the first line intervention, and also to establish high quality digital intervention, because before having one, you have to create one. So we need competences also there.
Yeah, thank you, Chiara. I just want to say thank you to all of those who work with us on the guideline. And actually, I'd like to mention that the guideline is in the December issue of the Journal of Sleep Research, and this is a special issue on insomnia. It not only holds the guideline, but I guess over 30 other articles on insomnia. So if you're interested in insomnia, just have a look at it. We now have 16 comments in the Q&A, and I think I will read out and you will decide who wants to comment on that. And there is the first, and I think we'll be cut off exactly at 5 p.m. So that will just happen. That will come down like a guillotine. We can't overdraw. So first question, could you share the sleep diary document consensus? This refers to the Colin Carney paper, and it is in the guideline itself. I guess all of you who are attending here also got a link to the guideline. It's a Colin Carney paper from, I don't know, it's the title is Consensus Diary. Okay, next one. Can you comment on biofeedback therapy and electrotherapy devices for insomnia treatment? Are they in the guidelines? Maybe I can, sorry.
Well, I just comment on your biofeedback. It's interesting. When I started out, you also, Dieter, and biofeedback was the new thing back in the 1980s. Not particularly in insomnia, there was an insomnia literature on it, but more generally in behavioral therapy practice. And biofeedback is obviously using feedback from bodily systems, whether it's muscle or heart rate or sensory motor rhythm or whatever, to help you with the process of relaxation. That was generally how it was used, as an aid to relaxation. And it's kind of come back a little bit now with the emergence of wearable devices, I think. I think one of the comments I would make is that your body is a biofeedback device. We know when we're relaxed and not relaxed. And when one thinks of relaxation exercises, one's often encouraging people to tense up a certain part of the body and then release the tension of that part of the body and notice the difference. So this biofeedback component is part of the process of a lot of cognitive and behavioral therapeutics, and indeed is part of the self-monitoring that people have when they're lying awake in bed and observing that I don't feel tired at the moment, I don't feel sleepy at the moment, or I do feel sleepy but I can't fall asleep. So biofeedback is inevitably part of what everything is about, but it's also a discrete form of therapy which has been less rigorously tested recently than it was historically 30 years ago. And that's partly because of its incorporation into wearable devices and the general lack of rigor around the research grade associated with those devices. That'd be my comment on it.
Yeah, I would just briefly comment on the electrotherapy. Yes, there is a brief paragraph about electrotherapy saying it's premature to come to a statement, a recommendation. Small studies, inconsistent methodology, interesting approach, but not yet at the level of maturity where we could say clearly yes or no about that. We will have to see in the future. What about adaptations of CBTI for people with circadian rhythm disorders? Can you share a key reference for adaptations like that?
Our book, the CBTI book published by Wiley has a chapter on adaptation of CBT for insomnia in cases of comorbidities with other sleep disorders.
Yeah, there is the Baglioni Espie Riemann textbook 2022 having a chapter on that, and in the special insomnia issue there's an article by Leon Lack who especially comments on the circadian aspects of insomnia and also on treatment approaches. We have the next question by Ludger Grote. He asks about, you're talking about actigraphy and PSG as diagnostic instruments. What is about in-between devices? Like he talks about the watch pad, this is a peripheral arterial tonometry, or devices with a combination between oximetry and actigraphy, or activity watches from the consumer market. What about that?
I can make a quick comment on that. I think one needs to differentiate between what we might call an evidence-based device, which would often be a medical grade device, and something that could be kind of evidence informed and so contains algorithms, but has not been itself tested under rigorous trial conditions or experimental conditions in a lab. And I think so therefore this is how you get medical grade kind of devices or measurement instruments, and consumer grade direct to consumer wearables. And I think it's very difficult to navigate. One's a more heavily regulated path than the other, and it's a business choice, I think, for companies to make. I think one of the things that we observe with a lot of the wearables is, although there are some studies coming out on them, is that there's perhaps fewer studies on clinical populations, and I think we need more of that research to be confident that these devices can be used in if you like, in treatment practice or assessment treatment practice. I think it'd be welcome to see more of that happen, but I think it's a big challenge because the medical grade devices are not released to the public until they're already regulated.
Yeah, excellent. It's the same as I see the point. Why do you still mention sleep restriction and not time in bed restriction? What about third wave therapies like ACT?
Well, I'll mention sleep restriction if someone else picks up an ACT piece. I mean, I think even Art Spielman, when he developed the term, and he kind of recognized quite quickly afterwards that it actually really wasn't restricting. It wasn't intending to restrict sleep. It was intending to promote sleep and sleep depth. And that more accurately, what you're doing is reducing the denominator in an equation, that is, restricting the amount of times people spend in bed, in order that the sleep they get can be more continuous and proportionately more efficient. But like many things, the term has stuck, like, you know, I think many people think perhaps it should be corrected to more time in bed restriction, but c'est la vie. That's what we have at the moment. But it's an important point.
Who wants to say a word about acceptance commitment therapy?
Well, I guess there is lots of research about third wave therapies as ACT therapy or mindfulness, with interesting results, but so far not yet so stable, especially long-term benefits, effects, stability of the effects of the interventions are not yet results are not yet consolidated, and for this reason they're not part at the moment of the recommendations. But definitely there is much interest about that, and there is already many of us adding emotional strategies in the standard protocol of the CBT for insomnia disorder. So I think, as Colin was saying, there will be also many updates about the CBT itself as a family of different intervention, as the CBT word goes farther, as more CBT experts get involved, then I think we also have much more advances in the CBT treatments itself.
Yeah, maybe I just select two more questions, and I guess then we have to stop. Digital CBTI could be refunded by insurance, question mark. I can say for Germany, yes, there's a digital health application law, and the insurances have to reimburse digital CBTI. I guess in the UK, or especially in Scotland, Sleepio is also refunded by health insurance, but this is up to each European country on itself. You know, these are decisions which are taken on a country, individual country level, and depending on your healthcare system. Let me see.
Can I just check, Dieter, when this seminar concludes? I thought it ran for another hour almost, but maybe that's not correct.
We are already through with an hour, and it's.
I thought I did a 2-hour slot in my diary, so just in case.
Erica, do we have 2 hours?
You can go ahead, Lisa. If it goes to 2 hours, if panelists are available, then sure.
Okay. Oh, great. Then we stay with all the questions. Sorry, I just thought we would be cut off. Okay. Then I go with all. Is prolonged release melatonin recommended for insomnia in migraine patients? And if yes, at which dosage? I guess I could say, Tiina, do you see it? Is prolonged release melatonin recommended for insomnia in migraine patients? And if yes, the dosage in adults?
So first of all, we don't take here any attitudes towards insomnia in the comorbid conditions, but rather they are on individual basis. And since I'm not a neurologist, I cannot answer directly to that. I would say that this would be in an individual basis. If somebody else wants to answer to that question, please go ahead.
Yeah, I guess maybe we go ahead. Why is, when that's a killer question, why is CBTI not offered in primary care?
Well, I can answer that. I don't think that is totally true. It is in some places in Europe. It is offered in primary care. I mean, there's lots of differences in different regions of Europe.
Exactly. Yeah. There's lots of difference, but I think exactly what these guidelines and all the evidence-based literature on insomnia is promoting is really a cultural change in interpretation of health system only as a one aspect, as organic based medicine, and more considering in health more a combination and a participation of different professionals. So, hopefully that will also be reflected in a change.
Yeah.
General point that might just be worth making is that whether it's CBT in primary care would, or any other either therapy, pharmacotherapy, or any future therapy to be invented, it seems likely that insomnia begins as a primary care challenge. Difficulty sleeping is such a common problem. It's such a common problem to reach a clinical threshold. And it's such a common problem that it tends to become persistent, as we saw in the epidemiological data earlier on, that it's inevitable, really, that it's a community challenge. How do you solve the insomnia dilemma? How do we treat insomnia? And indeed, at a community level, how do we prevent insomnia developing in the first place, which is probably a separate thesis altogether. But, I think, transferring a lot of skills, capability, and resources and training into primary care seems to be really important to my mind if we're going to treat insomnia effectively. We can't treat insomnia just by developing hospital-based sleep medicine services, behavioral sleep medicine specialties at arm's length. We have to find ways of developing some kind of step care system whereby insomnia is effectively managed early and quickly, not least in primary care, whatever treatments we're using.
Yeah, another very important question. What is the latest for combination therapy with CBTI and medication? I am aware of the Maureen sequential study. Thoughts about that?
If I can comment on that, so I think we need more research on that. Absolutely. This is something I would be looking forward to learn more.
Yeah, I fully agree with you. I mean, the Maureen studies are pivotal in that respect, combining and comparing medications and psychotherapy, CBTI, but we need much more work there, and we also need work, very near to clinical practice. But I guess at present it's not so clear that the results from the studies say combination is better than single therapies. I think CBTI always comes out best of these studies. But Colin, I don't know, maybe you have a better overview of that.
I think often what we're doing is we're comparing two traditions of therapeutics and the meta-analyses associated with these two, rather than primarily. So therefore, we're looking at what's the evidence from the CBT, broadly speaking, psychologically based treatment literature, and what's the evidence based from the pharmaceutical treatment literature, and they have been typically two different traditions and two different evidence bases. The amount of research that has been which has looked at combination therapies or sequential therapies, compared with the amount of literature in each of these two big silos, there's been very, very few studies in that central area. And I think another thing that's really important that is probably not typically considered in randomized controlled trials, where people are simply allocated to a treatment, is to consider choice. How do people choose to receive their treatment? Yes. It may be a rather somewhat of a moot point if in practice people can hardly ever access CBT. But let's assume a situation where both CBT and pharmaceuticals were available, at the primary care clinic. I think it'd be really important research to understand the choices that people make. The evidence base about which is the best route and the algorithms associated with that's interesting. But I think we need to understand more about informed choice. After all, that's important at every level of decision-making in medical practice. What do you want to do? There's two approaches you could take. Where would you like to start? And I think that also has to be brought into the research consideration going forward.
Yeah. Next question. Which rating scale would you recommend in an adult population in a clinical setting to assess insomnia? Which rating scale to assess insomnia?
Wow, we recommend the insomnia severity index. Is a very short and easy to give, or the sleep conditioning index. I would say one of the two.
Yeah. Good. Why is prolonged release melatonin recommended for up to 3 months? I guess that the point was because it has been studied for up to 3 months in comparison to other
Yes.
agonists. And the data support that use, and then the European Drug Authority has also approved of using it for 3 months. That's the main reason. So let's go ahead. What about CBTI in children with autism spectrum disorder?
Well, there are data in this positive results. All the pediatric population has studies have received important result. Unfortunately, not yet that the same amount of research that the adult population has received, especially in the pediatric population. I think there are some ages which are better covered with research than others. Like, for example, we have lots of studies with very newborns and infants, and then we have a few with adolescents and not that much research with school age children. But the evidence which is available is actually consistent with the adult with the results that research found with the adult population, and also when children present insomnia comorbid with the autism spectrum disorder or other disorders. I believe, in my personal opinion, in the pediatric population, one possible important aspect will be the differential diagnosis, especially with circadian rhythm disorders. So these are especially a population which doesn't decide alone at what time to go to bed. And if in the family there is no much attention or knowledge about circadian preferences, individual differences, and in bedtimes and wake times, then this might trigger sleep disorder, which might be confused with an insomnia disorder. So maybe a better attention to this aspect in this population might be promoted.
Another one, what do you think of ACT as a second choice of treatment for insomnia? Several studies recommended it as a choice, especially when CBTI is not working.
Yeah, maybe I can comment on that, and maybe just refer to something that both Chiara and Dieter mentioned earlier on about, I've advocated for some time that we stop thinking of CBT as a treatment, but we think of it as a family of therapeutics. And we have first, second, and third wave approaches to evidence-based psychological therapy, starting with behavioral therapies and then cognitive therapies, and then they became commonly combined. So we ended up with multi-component cognitive behavioral therapies. So we've got elements of behavioral therapy, elements of cognitive therapy, and then we have this third wave, which is presenting itself as different again. In fact, all of these things, all of the active behavioral treatments, all of the active cognitive treatments, and all of the active so-called third wave therapies are all cognitive and or behavioral therapeutics. In the same way as, we have pharmacotherapy and we have benzodiazepine receptor agonists and we have several Z drugs, we understand that these are all pharmaceuticals. But we then say, well, which family of pharmaceuticals were there? BZRAs? Well, which BZRA were you treated with? I think in time, what we'll see in the research is an evolution of the evidence base for each of these component cognitive behavioral therapeutics, not just for the multi-component one. And we're beginning to see that now with sleep restriction, stimulus control, for example, being looked at more specifically as single component treatments. When Dieter and I started off in this, I'd never heard of CBT. It was a word had never been invented. my first study on insomnia, I looked at stimulus control versus paradoxical intention versus progressive muscle relaxation versus placebo and weightless control. That was my first clinical trial in the 80s. No one was thinking of combining them at that point. And it's as if we're now going back to saying, hey, these individual things might work. So what we end up with, I think, will be, over time, a set of behavioral, cognitive, and other types of therapeutics. And within that, acceptance, commitment therapy, or mindfulness-based stress reduction, or mindfulness-based relaxation, whatever it would happen to be, will all be separate treatment components that can be evaluated. As it stands at the moment, I think that statement is correct. The ACT would be a second choice treatment because the effects of ACT on insomnia outcomes, sleep parameters, are weaker, generally speaking, than the cognitive behavioural therapy package. It may well be a very appropriate second choice treatment. I suppose the outcomes are more to do with accepting of the situation rather than resolving it. So it's a different kind of outcome that one's looking for in that situation.
Yeah, thank you. There is a specific question to Tiina. Is melatonin only possibly effective when circadian factors are involved regarding fast and prolonged release melatonin, or only the fast type?
Well, the meta-analysis on the quicker and prolonged types of melatonin, so findings are controversial, and we don't recommend it in this recommendation for insomnia as such, only if there is a circadian factor included, and in individuals prolonged use for the prolonged slow melatonin can be advantages. So for using insomnia, that's not enough data in no circadian factor included.
Yeah. That's so surprising. I mean, if you just,
I hope I answered the question if I understood it correctly.
Yeah, it's absolutely, Tiina. That's so surprising considering the whole melatonin hype. But if you look at the data for the quick release, the evidence for insomnia per se is not convincing. It's just not. There are studies on Riemann, and actually sleep onset latency goes down from 80 minutes to 70 minutes. That's highly significant because it's a huge sample. But is this relevant clinical effect if sleep or subjective sleep latency goes down from 80 to 70 minutes? And that are exactly the points we also weighed when judging the evidence. There is one more specific questions about drugs by Ludger Grote. So he says, you discussed extensively the evidence for CBTI and a meta-analysis, but not so much for the drug treatment. You just summarized the efficacy for several drug classes without discussing specific data from meta-analysis and treatment outcome studies. Can you please refer to your discussion in the expert group a bit more extensively, effect sizes for orexin, for BZs, for BZRA? Maybe I can start with that. The interesting point is that if you look at the literature done on sedative hypnotics and insomnia of good quality, and if you look at the literature at CBTI for insomnia, I would say that at least you find 2 or 3-fold more studies done in the CBTI field than in the drug field. Most of the work on the classic benzodiazepines comes from the 60s or 70s, and then the research stopped. There is work on the BZRA in the 90s. There's work on sedating antidepressants, etc. But the thing is, most of the meta-analysis, and I guess all of them, looking at drugs, did not do a real differential analysis of weighing BZ versus BZRA, because probably there wouldn't be enough literature. If you look at sedating antidepressants, I guess there are like 5 RCTs out there or something. If you look at antipsychotics, I don't know, there is not even one single RCT looking at that. So the differential weighing or paying attention to is somewhat related to the evidence out there. It's not that we intentionally neglected the drug side, but we took in we researched for all the meta-analysis, and there are just a few compared to the whole CBTI field, and that's at the basis of our statements. And judging efficacy or efficiency or treatment effectiveness is one thing, but you also always need to take into account the side effect profiles also.
Yes, yes. Yes, exactly. So in medication, it's not only about the clinical efficiency, how
Yeah, somehow. Tiina?
It looks like she's frozen again, Dita.
Yeah, it's frozen again. So I guess I can just guess what Tiina wanted to say. I guess it's judging what a drug is worth on the market or in a given patient. It's not just how effective it is for the insomnia, but it's also a side effect profile. And the interesting thing, if I know the hypnotic drug literature fairly well, and in the end, what you find more or less, either you take a benzodiazepine or you take a BZRA, you end up with 30 minutes more of subjectively experienced sleep. The orexin, the daridorexant literature also encompasses objective data, and I guess it's something like that, 30 to 40 minutes more measured by polysomnography. And that's why we thought this data is so important, because they not only did subjective measurements, but they also did objective measurements. Somebody congratulates us on such a thorough guideline. Thank you very much, Beverly David. Vincenzo Muto asks about what about teenagers? Different criteria for teenagers.
Maybe I could start to answer to that. There are not different diagnostic criteria for teenagers. And I see Vincenzo made also a question afterwards about recommendation, the guidelines. So the recommendations are only directed to the adult population. We do not have yet guidelines for the pediatric age. We do have evidence supporting CBTI. There's a recent network meta-analysis comparing different intervention in the pediatric, non-pharmacological intervention and melatonin in the pediatric population, and they do go in the direction of supporting CBTI as the most effective treatment. But it has also to be said that there is not the large amount of meta-analysis as we have for adults. There's a chapter also in the book we were mentioning before about adaptation of CBTI for the pediatric age, and is divided for infancy and toddlerhood, school-age children, and adolescents. I guess the differential diagnosis is very important at this age, and sleep hygiene might be for some adolescents a relevant topic in that case, and maybe motivational aspects should be also taken attention to. Like, not always is sometimes it's the parents that push the adolescents to have an intervention, so that might be assessed and considered in the intervention.
Yeah, thank you, Chiara. There's a specific question for Colin here. What do you think about the role of low arousal threshold in insomnia and sleep apnea as well?
Yeah, so this goes beyond the guidelines, of course. But I mean, I think it's really an interesting transdiagnostic kind of construct. Yeah, I suppose the idea is that the threshold for arousal or arousability may be a trait or a state factor which represents vulnerability to a disorder, and I know this has been looked at a bit in terms of respiratory arousals. And I think Michael Grander has also written a little bit about this in relation to insomnia. And when I say transdiagnostic, I don't just necessarily mean across sleep disorders, but really across mental health disorders in terms of vulnerability. I guess we've often thought in terms of transdiagnostic theory that hyperarousal may be a maybe a transdiagnostic component of anxiety disorders, for example, or trauma, post-traumatic stress, reactivity, insomnia, and so on. But so might having a low threshold for arousal in the first place. And I think it's really important that as we begin to think about the transdiagnostic components, and as mental health researchers and respiratory researchers, whoever, begin to look at transdiagnostic factors, that we do include sleep as part of that consideration, because sleep itself is a kind of transdiagnostic phenomenon. So I think there's a lot to be said for looking at such markers. On the other hand, I think historically it's been quite difficult to get research funding to look at things that are not like within a silo, or this is a study on psychosis, or this is a study on insomnia or sleep, or this is a study on dementia or something. And despite a lot of encouragement to look at research diagnostic criteria and transdiagnostic criteria, for example, in NIH, it's often been quite difficult to get research channeled into looking at commonalities across disorders. So that's my comment on that. I think it's got a lot of mileage in it as a construct that probably needs more dedicated research funding. Then, of course, different kinds of studies as well, because when we do randomized controlled trials, we are specifically disinterested in individual characteristics. We regard individual differences as kind of error contributions to the analysis. When one begins to look at phenomena such as this, one becomes specifically very interested into ways in which individuals differ from one another. And it's a different kind of methodology, but I think potentially a very exciting one.
Yeah, there are two questions which go into the same direction. It's again, it's about children and adolescents. I have to say the guideline was just about adults, so there's nothing in the guideline about children and adolescents, but I think nevertheless we can maybe answer it. There is one question relating to, is there anything new with respect to CBTI medications? Could one use daridorexant for teenagers with insomnia?
Well, I don't know. I mean, these are kind of off-label kind of questions, I imagine. And I think I guess my general rule of thumb here would be that guidelines and kind of medical indications that are on products and medicinal products for different kinds and potential side effects and so on are all things that one weighs up in the individual management of a clinical case. And guidelines are there to help people have a broad understanding of the area and to interpret their clinical behavior, but they're not there to as a kind of a harness on individual clinical behavior. Clinicians still have to make judgments in clinical practice contingent upon their license to practice and their expertise in the area. And that does permit, of course, off-label prescribing. And one has to bear in mind, too, that almost all treatment of depression in young people is off-label prescribing.
Yeah.
SSRIs are not particularly indicated for children, but practice probably means that many people under guidance are given SSRIs. So we're in that common ground here, I think, Tiina, of decision-making at the clinical level.
Yeah, I guess an important point of label use, especially medications in the insomnia field in children and adolescents. And I mean, there are legal ramifications behind that. And if you want to be on the safe side and you want to give daridorexant to a teenager, I would recommend calling the company, what they say about that. Probably it's a question of, are you insured for any kind of side effects and adverse effects then? And there might be a huge risk then in these cases where a rather new drug is used, and probably the company would say, no, don't do it, please. I'm not sure, but maybe call the company. Insomnia with short sleep duration, does it have the same therapeutic approach compared to insomnia with normal sleep duration? Do we know anything about that? Maybe I start, I guess we don't have differential diagnostic studies. We would need a study having, let's say, a huge sample of people with insomnia, half of them with objective short sleep duration less than 6 hours, compared to another group with, let's say, more than 7 hours of sleep, and then they should be double blindly randomized to different types of treatment. I guess we don't have that type of study yet. What sometimes, if you read the literature about objective sleep duration, what sometimes is insinuated between the lines is like, if you really have severe objective sleep duration, you would need drugs compared to CBTI, because, you know, the CBTI treats more the psychological aspects. But I guess there is really no evidence that CBTI is less effective in objective short sleep duration. And there's no evidence saying that drugs are more effective in objective short sleep duration than CBTI, as far as I know, but maybe the others can comment on that.
I'm not sure whether there's anything further we can add to that. What we say in the guideline itself. It does seem an important area to be considered, but I don't know that we can say anything more.
Yeah. Another question, I think, which can be answered briefly. Do you know of any guideline for the treatment of COMISA? I would say no, but I'd strongly recommend also that you check out the special issue Insomnia. There is an article by Alexander Sweetman from Australia, and he especially does studies on COMISA. So I don't think there's a guideline yet. It may come in the next years, but I'd recommend the work of Alexander Sweetman and to check out the December issue of Journal of Sleep Research. There's a full article on that. Would you recommend a trial of digital online CBTI in ME CFS? And I mean, CFS stands for chronic fatigue syndrome, and ME would be myalgic encephalitis, I guess. Would you recommend such a trial?
Well, I think it's always useful to understand, how improving sleep may impact on other comorbid disorders. And certainly many people with, to my understanding, people with chronic fatigue syndrome complain of difficulties over the 24-hour period. So it'd be interesting to know what is the impact of insomnia treatment on chronic fatigue. The unlikely team at Flinders published the Flinders fatigue scale a number of years ago, which was specifically to do with insomnia-related fatigue, and I think to look at attribution of fatigue. If people have got sleep difficulties and chronic fatigue, how do you attribute the outcomes associated with daytime symptomatology and nighttime symptomatology? So I think it's quite a complex trial to undertake. I think it'd also be useful to know more, and there may be a lot written on this that I'm unaware of, but I think it'd also be really interesting to know, just as a baseline, to what extent do people attribute fatigue to some kind of ME consideration, as opposed to an insomnia consideration if they have both those difficulties? And because I suspect that attributional component may also influence the style of the study you would do, and maybe the way you would interpret results. But I think it's a very important area to be looking at. I think another area that would be interesting in that regard is to look at how cognitive and behavioural approaches for insomnia, particularly the behavioural ones, could interact with behavioural activation therapy in the treatment of insomnia associated with depression and vice versa. So the thing is, lots of ways that one could look at crossing the boundaries between the disorder or disease states, and think about how behavioural interventions, singly and combined, may help more than one condition.
Yeah, I think the fatigue area is a very important area, which is really still totally neglected. There's some wind coming in now from the long COVID patients, and that money is invested in research. But till I guess 2 or 3 years ago, if you have some kind of significant fatigue, you're really out on your own. And there are not many people in the world who are specialists for fatigue or so, and sometimes it's not even taken serious. Chiara, you want to comment?
Just one addition that anyway, we need to pay attention. The digital online CBTI could be more than one kind of intervention, because we have online CBTI, we just are online, but we speak interactively as now, or we have a digital intervention guided. So you have always the possibility to have a contact with the clinician, to ask questions, to have a feedback, and there are the automatized digital CBTI. So I think we have a very nice instrument in meta-analysis, which is always more used, which is this network meta-analysis, which give us also a comparison of the efficacy of different intervention. And I'm pretty sure that much more research will come about not only the efficacy of an intervention for a specific population, but also hierarchy of intervention for a specific population.
One question I can do quickly. Somebody asked specifically, if we talk about long-term treatment with the prolonged release melatonin, what do we mean exactly? And does this mean the 13 weeks approved by EMA? Yes, we mean that. But sometimes we talk about long-term means 3 months, or starts with 3 months. And that would be 13 weeks exactly. Now there comes an interesting one by Iris van Tichem, a clinical psychologist who treats insomnia patients. The question is about artificial intelligence. She asked, could certain artificial intelligence models help in predicting which kind of person may benefit from CBTI? And she wants to work on that. She wants to connect to people who have big data sets, freely online available big data. Who doesn't want to have freely online big data sets? But maybe Colin, you can talk. I mean, I think you did something probably with your own data sets, like.
So well, there's as far as I can see, 228 people on this call. So perhaps there's other people who could help you with that, or could comment on that, and they have your email address there to contact you. I mean, I think one of the challenges, as already said, is if one thinks about personalized medicine, which is probably the equivalent of what this might be, which is what is the best approach to treatment for this particular patient at this particular time, and delivering the treatment this particular way against these particular outcomes, if one thinks about personalized medicine in those terms. So you're kind of referring conceptually to some AI model that may help you to define the characteristics of the individual. I think CBT is not suitable for that right now, because it's a conglomerate treatment, the components within that, maybe which elements of a personal presentation may predict that this particular element of CBT, a stimulus control approach, or whatever kind of approach it would be, might be suitable for this person at this particular time, delivered in this particular way against this particular outcome. So I think that there's potential there in this approach, if we have that variance in the intervention types properly measured against the correct outcomes, as well as the characteristics of the individual and the clinical condition. And I think I'd love to think that's the future for medicine broadly, including behavioral medicine. Whatever kind of molecule or algorithm we're using as the treatment.
Yeah. Next one. What would an active control for CBTI look like in a research setting? That is to say, how can you disaggregate the active ingredient of CBTI?
Well, I think that kind of is a corollary to one of the points that we've been making throughout this this webinar and this discussion, and that is a very, very difficult task to do when you've got non-specific a kind of multi-component intervention. Whereas once you're down to the specifics of the intervention, one of the things that Simon Kyle, my colleague in Oxford, has been doing with sleep restriction therapy has been to disaggregate the sleep restriction or the sleep compression element of it, or the time in bed restrictions we talked about earlier on, the opportunity to sleep, as a specific intervention compared with a control condition was just about stabilizing the sleep schedule. So once one gets down to the components of CBT, I think it is more likely that one can have an active a treatment control, or indeed create a placebo version of the treatment. But when it is a really complex intervention with many components to find that active control that matches for the characteristics of the treatment itself.
Yeah. Next question, it's coming back to the consumer sleep tracker devices. Does the availability of sleep tracking devices make insomnia worse by promoting worry or an unhealthy obsession with sleep? Do we know anything about that?
Could I just stop at pause at this point and ask you if there's any journalists on this call that they declare who they are? You know, because there are a number of questions from anonymous attendees, and they seem totally valid to me. But I'm just aware this is a public forum, so one should go. So, you know, just in case people are using this to you know for media purposes. That said, I'm happy to answer the question. But you know, I think if anyone, you know, if there is anyone there who was there with that background, it would be helpful if they declared that to the organizers at any rate, especially when there's specific devices like Apple Watches and Fitbit. We're not here to comment on the strengths or limitations of any particular device, and I wouldn't want to be quoted in that way. Is that fair to say, Dieter?
Yeah, absolutely. I guess thanks for bringing this up. That's an important point. Yeah. Next one, easier.
Can I?
Yes, Tiina.
Can I also comment that yes, when talking about insomnia, so it really is a subjective a disorder based on subjective measures. So that's, I think, something to bear in mind. That we follow the subjective symptoms, and it's diagnosed by subjective symptoms, and we also follow the subjective symptoms when we treat the patients.
Yeah, I mean, I guess there is an important point.
It's also reasonable, of course, to have consumer grade treatments and consumer grade devices. I mean, that's the way we live our lives, right? You can go into a high street store and you can buy lots of vitamins or lots of things that may help. You could buy lots of devices, have them around your home, or wear them on your body, or wear different clothes, or whatever. You know, the evidence-based requirements around those things are quite different, you know, consumer grade, from things that are for more clinical. And we're here really, I think, primarily to talk about clinical guidelines. So I just want to say that I think it's perfectly legitimate to have consumer grade choices that people can make, but I think that that's a different consideration from the clinical domain about whether something's an effective, regulated approach to treatment or patient assessment. You know, so I just want to clarify that the overlap between these two things is less real than people imagine. We've lived for a long time with a pill and a pill, knowing you can buy one in the shop, another one you get as a treatment, and people know that's different already. So you need to understand that these are completely different things.
Yeah, let's go ahead. Are there special rules for CBTI during pregnancy? Can you recommend some literature?
So maybe I can start here. There are yeah, there are not guidelines for pregnancy, but there are adaptation of CBTI for pregnancy, especially regarding sleep restriction. Actually, we do not have evidence showing the sleep restriction might be dangerous in pregnancy, but in some way we don't want to try it. And so in this case, we suggest to do the sleep compression intervention instead of sleep restriction, which is a milder form of reducing the time in bed, but gradually reducing the time in bed until you reach an optimal window of bed time. And other attention are dependent on physiological changes, and it is suggested also to include maybe a module on postpartum to educate women to what will happen next, to what they have to expect. And about recommended literature, there are a few papers about a task force of the European Insomnia Network, especially about pregnancy and peripartum, and there is a chapter always, I'm always quoting the book, but this book is actually taught to have adaptation of CBTI for specific populations. So there is a chapter dedicated to the women lifespan, so to puberty and pregnancy and menopause, and there is suggested protocols to use in clinical practice for pregnant women presenting sleep difficulties.
And also in UCSF, San Francisco, Jen Felder has got an active program of research on women's health and insomnia, including studies on CBT in pregnancy. And at the Henry Ford health system in Detroit, David Kalmbach and others are also been studying this. So there is an emerging literature, randomized controlled trial literature on CBT during pregnancy, including during the third trimester of pregnancy, during which time very often there are difficulties with symptomatic restless leg syndrome, which is interesting that even in the context of that as a potentially contributing factor, that there seems to be some evidence emerging that a behavioral approach or cognitive behavioral approach can be helpful. So I think it's a really important area, because one thinks in many circumstances where because of such factors, people may be less inclined to want or to take medication, and it may be less commonly prescribed. So question is, can CBT help? So that, these are the kinds of things I think, that when we earlier on were discussing, but why do we need an update in the guideline after only 5 or 6 years? These are the kinds of studies that have emerged in the last few years on populations like pregnant women. Who would have thought that would be looking at treating insomnia in pregnancy? But there you go, there's research emerging.
Yeah, next question. What is the most relevant sleep-related outcome measure for insomnia research? Is it the SCI, which is the sleep condition indicator? Is it the IC, the Insomnia Severity Index? Or should it be an objective measure like WASO, TST, or sleep efficiency?
Maybe just a comment. First, I wouldn't speak about objective measure, but about physiological measures to avoid to give a kind of superior interpretation. We know all instruments have their own biases. And then in context of insomnia disorder, I would definitely refer to the self-perceived symptoms, so either the 2 scales which are mentioned or the sleep diaries data.
Yeah,
I think it's interesting as a question is because if one looks at the depression area or anxiety or whatever, we regard ourselves as fortunate to have a choice of scales, all of which have got the strengths and have got the psychometric strengths and limitations. So we've got the Beck Depression Inventory, the quick inventory for depression symptoms. We've got we've got hospital anxiety depression scale, we've got the PHQ, etc., etc. We've got the Hamilton scale. And I think it's good that we have all these measures of depression, which give researchers and clinicians choice. I think it's good that we also have several measures of insomnia symptomatology, rather than just settling on the one. And because then it's up to us as clinicians and as scientists to decide for this given purpose what's the best measure to use.
Yeah, there's another question here which I can answer very briefly. Do you recommend other DORAs like lemborexant? No, we don't. Lemborexant is not available in the European Union, and so it's not part of the guideline. Can you please comment on sleep compression, gradual reduction of sleep window versus sleep restriction?
I think there's maybe some brief description of that in the guidelines. I'm not sure if there is. Chiara, do you know?
Yeah, there might, and the rationale is the same of the sleep restriction intervention, but it's a milder form. So either in cases as pregnancy or sometimes also with bipolar disorders in which too strong sleep restriction might have negative effects, or even just when the patient is not adherent to the treatment, find it too difficult, too scary, then it could be an effective option to reach the aim. I think we always have to make compromises and individually tailoring our intervention to the patient, but with awareness and good information. So the patient has to know that we are choosing a way which might be longer, softer, but longer to reach the.
Well, I think that's a really good point. If you imagine, if you take as your index, what is the baseline sleep efficiency? The estimated total sleep time relative to the time spent in bed expressed as a percentage. If someone is reporting a very, very low sleep efficiency, then the prescription, shall we call it, according to sleep restriction, could be very, very severe and difficult to adhere to. So therefore, the clinical consideration often is how do we help this person begin on the therapeutic journey? And sometimes that can be by compressing the time spent in bed rather than reducing it down so dramatically. And helping the person to adhere to a treatment intervention is part of clinical practice with any type of treatment. It's pointless to give people treatments they simply can't swallow. Pills, you wouldn't give a patient a pill they couldn't swallow, would you? So therefore we have to think of behavioral interventions as, in that sense, as things we have to implement. And it's our part of our responsibility as clinicians to enable them to do that. That said, I think it would be very valuable to have a stronger research evidence base looking at sleep compression in relation to sleep restriction and the kind of protocols for administering those in relation to presenting characteristics and treatment preferences that people may have.
Yep. Okay. Next one. Could you give some recommendations on when prescribing orexinergic drugs, dose, side effects, and how to educate the patient on the expectations around these drugs, please? Thanks. Actually, I think this would go beyond our role. I mean, it's clearly that each physician who treats patients has to really study the package insert, and insofar, I'd say it is not different from any other kind of hypnotic drug how you use it. But maybe Tiina, you want to say a few words about that?
Well, as usually, the sleep medication is recommended taking about 30 minutes before going to bed and exactly follow the recommendation of the dosage, which for daridorexant is to use 25 to 50 milligrams. Some patients do feel nausea and vomiting next day, so it might be good to it's always good to warn the patients of the most usual side effects. I must also say that we have not been using it yet in Finland, so this is also now only theoretical considerations I'm giving. But
Yeah, but I would really say, I mean, we can't go beyond what is in the package insert and what the regulatory authorities say. I mean, we don't have more experience than them, and then we can't come with anything new there. What is your opinion about peripheral autonomic nervous system stimulation for insomnia as a complementary treatment? Actually, I'm not so sure whether I really know what that is, what is meant by that. And actually, we did, the guideline analyzes complementary alternative treatments and says there is some hope for the future for exercise and light treatment as kind of complementary treatments. But all the other methods, we had a look at it. There is no good evidence out there. There is nothing like randomized controlled double-blind studies or so. So I would say our opinion is it's not it's not recommended.
Yeah, I think there's probably an emerging interest and literature on stimulation techniques of different kinds, whether peripheral or more central. But the literature's probably at a very early stage. But I encourage innovation in understanding not just whether those kinds of interventions work and using the recommended ways to evaluate treatments, but also to understand really from the outset, if possible, what is the proposed mechanism of action of new treatments. Because I think one of the things we're doing kind of retrospectively here a lot of the time with cognitive and behavioral therapeutic interventions is trying to, after the event, we find a treatment that well, this works, and then we think, well, how's it working? What's it doing? So I think it would repay if novel treatments are from the beginning trying to consider not just whether a new intervention approach works and generalizing it, say, from the treatment of pain or something else into insomnia, but actually understanding the mechanism along the way.
Yeah, there is a question regarding the discrepancies between objective and subjective measures assessing insomnia. I would say I would recommend here the article by Francesca Ciclari in the special issue of Insomnia published in December, but I'd also like to invite other panelists to comment about that. I guess it's really...
If I comment.
Yes, Tiina.
Yeah, well, as already earlier, so I think it's that we rather describe about this physiological and then individual psychological measures, and there are no objective or physiological measures that are kind of the diagnostic criteria for instance. I as a psychiatrist prefer symptoms and the experiences of the patients, and I think they are valid even though we would not have any physiological equivalencies. And then patients are of course very different also in that sense.
Yeah, and I'd just like to add that in her article in the special issue, Francesca Ciclari says we talk about misperception of insomnia, but shouldn't we not talk about mismeasurement of insomnia, which I find a very nice turn. More information about light therapy for insomnia without circadian disorder. I guess also in the special issue, the article by Leon Lack should be very informative, but anybody else wants to add something here?
Yeah, I mean, I think we have grown up with sleep research and sleep medicine, and sleep science, sleep medicine, sleep research, and circadian science and circadian measurement, almost like two separate fields of study. And I think we see more and more interest in understanding how the sleep and circadian system provide mutual feedback to each other, and therefore also how there may be insights about intervention that come both from manipulating sleep, if you like, sleep therapeutics, and manipulating circadian parameters, if you like, circadian therapeutics. And I think this is really going to be an important area for the future. because the chronobiology area has not really translated very much so far into therapeutics at the level of treatment. And the most prominent candidate, is the judicious use of light to help circadian timing, and thereby also to improve sleep homeostatic function and potentially to treat conditions. We've also seen the overlap being very, very important between, say, insomnia and delayed sleep phase problems, and as Chiara mentioned earlier on, particularly in younger people and more often called special populations, the importance of circadian factors as well as sleep factors in developmental disorders. So I think this is a really, really important area going forward, and I think it points to the research agenda that the guideline, if not explicitly, then at least implicitly, points to the kinds of things that one would hope we will see more science on and more good outcome research on by the time we do this again in another number of years, or the next generation of people do it, Dieter, if not us. So when things are in the guidelines as not enough evidence or insufficient evidence, this should be seen as an encouragement for further research, rather than this doesn't matter. And I think light therapeutics combined with behavioral therapeutics in the CBT toolbox, could be very, very influential in helping many, many conditions, not just clinical ones, but things like shift work disorder and other things like that.
Yeah, somebody's looking for the Academy for CBTI, but cannot easily find it. Chiara, you can help there, I guess.
Yes, if you don't find information, you can always write us for information, both for the European Insomnia Network or the Academy, right?
If anybody wants to become a member of the European Insomnia Network, just write an email to me. I have the mailing list and I can easily add you to the mailing list. So I guess we're through. It's 6 p.m. here in Germany, 7 in Finland, I guess, 5 in Scotland, and 6 in Italy. So I guess we really had a great webinar here, and I was really overwhelmed by the questions. I guess we went through almost 50 questions, and this also shows there's a need to discuss these things, and maybe we take it up next year with anything else insomnia related. So I'd like to thank again at this for so many hearts and clapping hands are coming on. Wow. And
I wish I knew how to do that.
Oh, I faked this initially. No, I guess these are really true clapping hands and hearts. Thank you. Thanks the ESRS for hosting this and for coming up with the idea. Thanks to Tiina in Helsinki. Thanks to Colin in Scotland. Thanks to Chiara in Italy. I guess it was really worth it to have this webinar here. We're looking forward to the next year, and also especially to the ESRS meeting in Sevilla. So if you want to have a real great experience with the scientific meeting many insomnia people and researchers and other people, then go to Sevilla. Looking forward to meet you there. And I'm saying goodbye. Not yet good night, good afternoon, but goodbye.
Let me have
Thank
the
you,
last
Dieter,
word.
to organize that.
Thank you, Dieter,
Bye.
for your leadership.
Thank you, Dieter, and everybody.
Bye.
Bye, Colin. Bye, Tiina. Bye.
Bye.